So I thank the speakers for a very warm introduction. So I'll start without further delay. So as we all know, we are in the middle of monsoon and middle of very viral infections going on. So what, as an hematologist, I can add to the treatment of the viral infections. So I'll deal in the topic. The scope of the topic is hematological complications, especially cytopenia in viral infections, available diagnostic and review of multiple treatment options. We'll do a case-based treatment options review and possible hematological complication, role of hematologist. So three major viral infections we are dealing here. So one is dengue fever. We have a lot of senior physicians in the audience who are much more capable of treating dengue fever. But just to enlighten, what is the role apart from transfusion and how can we manage hematological complications in dengue fever, COVID-19 infection, and chronic viral infections, various hematological issues. So, sorry. So we start our first patient. So he was our 24-year-old. He's a resident of Aurangabad. He's a bank manager. He was symptomatic for fever, rash, body ache since 2 days. So fever workup is day in NS. Very simple, straightforward. Coming to a fever OPD day in and day out. Dengue NS1 positive, diagnosed as dengue fever. So last year also he had similar dengue fever. So then day one he was stable. He just had a rash. Nothing significant. Hemoglobin 14, total count normal, the platelets slightly on the low, but normal, LFT, RFT normal. So it's a typical dengue fever. So we do a routine management, paracetamol, and monitor hematocrit and hydration. So day 4, then what happened? He had an abdominal pain, which was mild. He was all febrile, pulse is 65, BP is almost 110/80, slightly high. The pulse pressure is on the lower side. No PTK, no ecchymosis, mild tenderness in the right hypochondriac region. There is slight hemoconcentration, which is there, slight leukopenia, and slight thrombocytopenia. Apart from that, his SGPT is slightly elevated, his APTT is 40 for the control of 34, and fibrinogen is normal. So this is a early dengue hemorrhagic fever. What we are seeing is a compensatory phase, in the compensatory phase. So apart from your routine management, you are very well aware. But apart from that, what can be approached here? The role of steroids, any thrombopoietin analogs, platelet transfusion, very famous papaya leaf extract, any prophylactic role of antibiotics, plasma transfusion. What we will go through each of this in the subsequent slides. So what happens in this phase? Actually, there is thrombocytopenia, there's increased APTT, decreased fibrinogen, increased D-dimer, activation of fibrinolysis. So why is this happening? Because when we reach the critical phase, which is the start of the dengue hemorrhagic fever, there is activation of the cytokines due to activation of the natural killer cells, memory cells. There is an endothelial damage. Because of the endothelial damage, the glycocalyx, which is beyond the endothelium, it is liberated in the circulation. Because of that, the heparin sulfates are also liberated, which increase your APTT. There is a plasma leakage which is happening, which is due to the endothelial damage. So you have a decreased fibrinogen. There is increase in the fibrinolysis. So all this can lead to manifestations in this phase of dengue. So what exactly causes thrombocytopenia? So thrombocytopenia in any viral infection, especially dengue, there are two factors which lead to thrombocytopenia. Early phase, which is the viremia phase, and the later phase. So the early phase, there is a direct suppression of the marrow. There's infection of the megakaryocytes. There is decreased TPO production due to the various cytokines, so they decrease the production of the platelets. What happens also, the enhanced platelet destruction due to the direct viremia, due to antibody mediated clearance, due to macrophage activation, due to various other sequestration in the spleen. So all these factors lead to thrombocytopenia. Until and unless we go to the details, okay, why thrombocytopenia is happening, in which phase of illness, we may not able to treat it accurately. So bleeding in dengue is not always related to thrombocytopenia. Bleeding in dengue is much more beyond thrombocytopenia. So why it is like that? So it's not directly related to the platelet count. It never correlates with the platelet count actually, because there are multiple factors. There's capillary leakage, decrease, deranged PTTK, decreased fibrinogen, circulating heparan sulfate, which acts as an anticoagulant. There is activation of fibrinolysis, which can all lead to bleeding. So whenever we see dengue, we correlate ki haan, platelet kam hai, he can have bleeding. But beyond platelets, also bleeding can happen. So thrombocytopenia very poorly correlates with the bleeding manifestation, and spontaneous bleeding in common even when counts below 10,000, and it's strongly associated only severity of vascular leakage. If there is no severe vascular leakage, spontaneous bleeding may not happen even below counts less than 10,000. So there is a very important fraction. This is a immature platelet fraction. This can detect your platelet recovery. So the normal range of this immature platelet fraction is 3.6 to 9. So what they have done this study. So they have said that the IPF more than 10% after defervescence, like after your fever has gone, everything has gone, you are in the critical phase, and the IPF is rising. Then you say that, okay, the platelet will recover and within the next 72 hours. So then you can avoid unnecessary transfusion in this phase where your IPF is rising. And IPF can easily be available on any 7-part hematologic cultures. So now we go to the phases of this dengue. We have the early phase, we have a compensated phase, and we have an uncompensated phase. So steroids WHO doesn't recommend steroids in dengue, but there are various studies which have done, and these studies we have summed up in this 3-4 slides. So what they have done in the preliminary stage, they have tried low dose and high dose. So they have said that low dose, this preliminary stage, low dose has no significant benefit. There's only one study with methylprednisolone, and that is showing benefit in terms of prevention of dengue hemorrhagic fever, in prevention of shock. So, but one study benefit is inadequate to make any conclusions. So what happens in the intermediate stage, when there is an early dengue hemorrhagic fever? So in that, they have tried with the various doses, various other routes. So hydrocortisone single dose, hydrocortisone 3 doses, single dose of methylprednisolone, and various other doses they have studied. So what consensus they have said that single dose hydrocortisone is no much benefit. High dose methylprednisolone, hydrocortisone in the range of 1 to 3 milligram per kg, they have benefit in hemodynamic improvement. They stabilize your endothelium, they reduce your capillary leakage. Not directly, it may not directly increase or decrease, it may not directly increase the platelet count, but they decrease all the immune associated mechanism of platelet destruction. So they have benefit over in reduced bleeding. Sorry. And what happens in the late dengue hemorrhagic fever? Then the late dengue hemorrhagic shock, whatever you give, there is not much benefit once profound shock has set in. So this just on the basis of some studies, some trials, but there is no much randomized control trial to say this. But yes, they have studied steroids in various phases of dengue, and their conclusion is in the intermediate state, like the early critical phase, your high dose methylprednisolone, hydrocortisone have given some benefit, but still WHO doesn't recommend to give steroids at present because there's no randomized control trial for steroids. So what is the role of platelet transfusion? As Shashikant sir has clearly said do's and don'ts for transfusion. So this is one very good multi-center open label randomized trial where they have seen the role of prophylactic platelet transfusion versus supportive care. So prophylactic platelet transfusion, their cutoff was 20,000. So there is no role of prophylactic platelet transfusion in patients without bleeding. So in dengue, there's no role of prophylactic platelet because bleeding is much more beyond just platelets. So there's no role, and it may harm the patient by various other transfusion reactions, fluid overload, and many other problems. So what are the transfusion indicators? The packed cells, if there is shock, which is not rising with the routine fluid management, and there is a drop of hematocrit. So there is some concealed hemorrhage which is happening. So at that time, you have to give a packed RBCs. Platelet, there is no need to give prophylactic platelet, even less than 20,000. Only when there is a bleeding, prolonged shock, coagulopathy, and associated massive bleeding, platelets are to be advised. Prophylactic platelet transfusion in the if platelets are less than 10,000 and there is evidence of capillary leak going on, then yes, you should give platelet transfusion. Also, fresh flows and plasma or cryoprecipitate if the patient is in very late stage shock, DIC, then you can have, or some other indicators like we will see in the further slides. So what are the role of thrombopoietin analogs in viral infection? So we have two thrombopoietin analog, which is L-thrombopac, it is oral, dose is 25 to 150. Another is romiplastin, which is subcutaneous, 1 to 10 microgram per kg. And we discussed like they act on the thrombin receptor and increase the platelet production. So theoretically speaking, there is a TPO deficiency which is happening. There is a decreased megakaryopoiesis which is happening because of the viremia. So theoretically speaking, they may have some role. But to study this role of L-thrombopac, there was a phase 2 randomized controlled trial in dengue patient to study the efficacy and safety of L-thrombopac. So what they have done, they have divided in 3 groups. One group they have given 25 mg, second is 50, and third is a control group. And they have started from day 0 to day 7. And they have seen the platelet recoveries and other features. So, but this is just single study. So we need more evidence for routine use in dengue. Also, they have not given insights and long-term data. We don't have what L-thrombopac does. And also there are a lot of thrombotic complications with these agents. So these agents have a lot of thrombotic complications. Also in dengue viral infection, you are at a thin line between bleeding and thrombosis. So before using these agents, you should be clearly sure that why you are using these agents. Also, they are not for active bleeding because they take time. They take time to act. So like they may not be useful in active bleeding, in shock and everything, but you should have much more evidence to suggest. Also, romiplastin, there is only single case study use of dengue in romiplastin, use of romiplastin in dengue for single case study they have reported. So this is an incomplete evidence to support the use of thrombopoietin analog. Also very popularly, everybody is taking CARICA leaf extract, which is a papaya leaf extract in dengue. Right, left and center people come with all those pills ki this is beneficial or not. Yes, theoretically CARICA leaf extract is a thrombopoietin stimulant. It stimulates the thrombopoietin. But there was a systemic review and meta-analysis. So they said ki, the clinical value, the theoretical value, maybe it is a thrombopoietin analog, but the clinical value of improvement in the platelet count or early discharge is unclear. And this current evidence is insufficient to comment on the role of CARICA leaf extract in dengue. So this needs to be told to our patients ki, they may take, but we don't know what is the exact benefit of the CARICA leaf extract. So we continue our patients. So we have seen a typical dengue hemorrhagic fever. So what happens further? So we continue. We have few scenarios. What happened in viral infection and how do you deal with different thrombocytopenias? So what happens? The same patient on day 8, he starts spiking again. He has high fever. There is a petechial rash. Spleen is palpable. So what has happened now? So his hemoglobin is 14, his count has dropped, his platelet has dropped. So count is 1640, platelets is 15,000, and he's having persistent fever spikes. So his SGPT is elevated, his fibrinogen is less, his ferritin has increased. So what are we dealing with here? So we are dealing with HLH. So patient is going into HLH, which is a very common scenario in a viral infections. After patient has recovered and then patient starts fever, spiking fever again, and there is pancytopenia. So this is an experience from 180 patients of dengue fever. So HLH is a very fatal condition. It has to be identified early and treated early. So when do we suspect HLH? So there is a resurgence of fever after defervescence, persistent fever not related to any bacterial infection, pancytopenia, very high ferritin, low fibrinogen, high triglyceride, splenomegaly, and when we do a bone marrow, we find hemophagocytosis. So this is a criteria for HLH. So it needs high suspicion, rapid treatment, and highly fatal condition. So we start with dexamethasone and plus or minus etoposide. So what else can go wrong with viral infections and thrombocytopenia? So not the same patient, but we give another scenario. So his discharge, he was doing okay. So we asked him to follow up after a week, but he comes to the casualty with seizures on day 14 and altered sensorium and jaundice. So what has gone wrong with him? So he's irritable, drowsy, there are purpuric spots, he's pale, icteric, there's no hepatosplenomegaly. So his hemoglobin is 9, his count is fairly okay, platelets are down. And also SGPT is normal, SGOT is on the higher side. PTA, PTT, fibrinogen, everything is normal. There's indirect hyperbilirubinemia and creat is also on the higher side. We suspect what has happened with him. CT brain is done because he has developed seizures and ultrasensorium. CT brain is perfectly normal. So what are differentials? He may develop IC bleed, there may be liver failure, sepsis, he may have acquired leptospirosis, or is it TTP? So very well, TTP can happen in dengue. We see the smear, there are schistocytes, there are microspirocyte, polychromatic cells, retic is high, LDH is 1300. Again, emphasis on good peripheral smear examination. So we diagnose them TTP. So why does TTP occur in dengue? So TTP, this is a normal pathophysiology of TTP. So in dengue, what happens? There is endothelial injury, there is activation and release of ultra-large 1 millivalent factor. There is ADMTS13 defect, mostly immune mediated, and which causes platelet-rich microthrombi and then lead to TTP. So management do's, we give urgent plasmapheresis, plasma infusion, methylprednisolone, SOS rituximab. Don'ts, we do not transfuse platelets in TTP because it aggravates the condition. So scenario 3, what happens? So his discharge is good. He said we'll come monitoring for platelet count. And then again, after a month, he's admitted with petechial rash, gum bleeds, epistaxis. This time he has mild pallor. He's stable, not sick looking, very stable patient walking to your clinic with bleeding manifestations. So this time platelet is 5,000, rest parameters appear to be okay, mild anemia. So persistent thrombocytopenia post-dengue fever. So what can lead to persistent thrombocytopenia post-dengue fever? It could be immune thrombocytopenia, and aplastic anemia also is reported post-dengue fever in some. So it may be directly related to dengue, or some may be just coincident. He may be having megaloblastic, but platelet is too less for a megaloblastic, MDS, or a coincidental acute leukemia. So there are case reports of chronic immune thrombocytopenic purpura post-dengue hemorrhagic fever. So the diagnosis is just on peripheral smear. We calculate the actual platelet count, the size, any other evidence of hemolysis, any abnormal cells, bone marrow megakaryocytic hyperplasia, the standard treatment of ITP, whatever we do for our standard ITP. So we do a standard treatment for ITP. We see whether he has severe bleeding symptoms, non-severe, then decide to give steroids, IVIG, plus or minus. So this is the standard treatment of post-dengue ITP. So we move on to our next this is the upcoming infection, and what COVID-19 has affected hematological manifestation of COVID-19 apart from thrombosis, because thrombosis, this is not the scope of my topic here. So there can be lymphopenia because of the infection of hematopoietic cells, direct cytotoxic effects, infection of spleen and lymphoid organs. There can be thrombocytopenia, like we said, previous viral, all viruses have same mechanism of thrombocytopenia and thrombosis. So these three are very important pathophysiological hematological changes in COVID-19. So thrombocytopenia post-COVID is a very important known entity. Generally 3 to 4 weeks post-COVID, mostly immune, like immune thrombocytopenia, we treat them. Most important differentials when the patient is admitted with COVID and in early COVID he gets thrombocytopenia. We need to rule out heparin-induced thrombocytopenia, TTP, whether he's developing HLH, or a very upcoming entity which is a multi-inflammatory state. This is seen in children, but adults can also present with multi-inflammatory state post-COVID and leading to thrombocytopenia. So chronic infections, many of the time you have a patient of thrombocytopenia, and HIV is the cause for unexplained thrombocytopenia, is frequently missed. Also HIV can present as lymphoma, leukemia, so with thrombocytopenia. Similarly, hepatitis B. So all cytopenias, we need to do HIV, HBs antigen, HCV. This is state standard for every thrombocytopenia, identifying causes of thrombocytopenia due to direct viral infection, due to immune mechanism, specific antiviral therapy, and then if required, SOS romuplastin, L-thrombopac, IVIG can be used in above conditions. So what are the take-home points? So bleeding in dengue is multifactorial, consolidated therapy rather than focus on transfusion. Sorry. Monitoring IPF can avoid unnecessary transfusion. There is role of steroids and thrombopoietin analogs seems promising, but needs more evidence to form guidelines. And there is very thin line between bleeding and thrombosis. And whenever we manage patients, we need to be on the thin line and decide whether Okay, bleeding, to treat bleeding. Thrombosis, risk of thrombosis, so manage accordingly. So I thank you everybody for a very patient hearing. Thank you.
Thanks, Dr. Shruti, for the very much informative lecture on this topic. Actually, in dengue, the duration of thrombocytopenia is very short. So, if you wait for some time, the thrombocytopenia will automatically recover. But trigger is given as 10,000 or 20,000 depending on the situation. For any blood transfusion, any blood component transfusion rather, um, transfusing a patient is not a decision on laboratory markers. It is your clinical decision. So I'll always say that what is the clinical condition of the patient, that depends whether whether to transfuse or not to transfuse. We definitely have some triggers, but it is the decision of clinicians. So you have to decide whether the patient should be transfused or not, depending on the other clinical situation. Thank you. Thank you, Dr. Manoj Toshniwal, sir. It reminded me 25 years back, I attended Dr. M.B. Agrawal sir's CME at Bombay Hospital. I think he was instrumental in starting that CME at Mumbai, and you are instrumental here to start this CME in Aurangabad. I also thank IMA Aurangabad. Thank you. Thank you.
Thank you, Dr. Shruti. It was a very informative and wonderful lecture delivered. And I would like to congratulate Dr. Manoj and Dr. Shruti and wish them all the best for their wonderful future. And Manoj, I can say that we are very much proud of you being a GMC mate, and he was my SR also, senior resident, because I have done in-service post-graduation. So even though he is younger to me, but he was my SR. And I know he is very sincere. He has passed his entrance examination, PG entrance examination in the first attempt when he was intern. So he's very, he's on top of everything. He's a very, very good human being. So wish you all the best, Manoj. And thanks IMA, and thanks for inviting me for this event.
Thank you so much, Padmaja Madam and Manju Madam, for such a nice words. I would like to request Shubhangi Change Madam to come on dais to felicitate our speaker, Shruti Anup Toshniwal Madam. She has given such a nice lecture on routine thing, which routinely we all face this problem. Dengue patient coming with thrombocytopenia again and again. Thank you. I request Dr. Riya Vallikar to felicitate our chairperson. I request